Morning, everybody. Hopefully you can hear me okay. This morning, thank you so much for joining us. Just going to start with a karakia. Tūruki whakataha, tūruki whakataha, homie, huie, taikie. Thanks for joining us this morning. My name is Celia Palmer, for Celia Palmer Tokaringawa, and I'm going to be joined throughout the session this morning by the panelists that you see below. Louise, who's one of our nurse specialists, Stephanie, who's a nurse practitioner with the team, Amy McDonald, counsellor, and Patricia Gosper, one of our social workers. So this morning we're going to talk about care of people living with addictions. I guess the challenge is really this. As a primary care provider, you might find a patient walks into the clinic, they're on the methadone program, they have been for some years. As far as you know, they're not currently using recreational drugs. They've recently been diagnosed with metastatic disease. By the time they go out, you find you've given them immediate release morphine to manage their pain, which you can't imagine having done to a patient like this. And then you think it'll be enough for a month. A few days later, they're back needing more. So I guess first of all, I would just wanted to reflect on, because we have got a few of these poll questions to get you involved with us. So the first question is whether you actually have had to manage someone with a substance use disorder who's also under palliative care services. So those are the options that you have. We'd love to hear from you. I'll just give you a few minutes to answer the poll question. I'm not allowed to vote, so. Okay, so actually I'm surprised by the answers because we've got quite a few people saying occasionally. Actually the most common answer was occasionally, which is 39% of you. Then rarely, never, and a very small number said frequently. So yeah, pretty surprising. Thanks so much for that. Obviously quite a big challenge for some of us. So how common is it? Let's just have a wee quick at the figures, and I am going to go through these pretty quickly so that we've got time for discussing the cases and for chats with the panel. So first of all, a definition. This is, I'm sure there's many of them, but this is one of them. And I think the part to point out that's genetic, psychosocial, and environmental factors all influencing how it develops and the manifestations of addiction, and that the behaviors are exhibited are impaired control over using drugs, their compulsive use continuing despite harm, and craving, which is actually one of the latest ones added here. So here we have the DSM-5, which some of you might be familiar with. And there's that points out 11 criteria, and they fall under 4 categories: impaired control, physical dependence, social problems, and risky use. So there you are, that's the DSM-5, which as you can see has changed more recently, and I thought it was interesting that they've added craving to this list. Basically, you would only need 2 criteria, more than 2 criteria, to fulfill the diagnosis of a substance use disorder. So I'm making you work this morning, so I've got another question here. How common do you think it is among our patients in palliative care? So pretty low to, relatively 20% would be quite a big sample. Again, we're just going to give you time to answer. This is the bit where we collate your feedback. Coming. So most people have said 2 to 9%. I think if we look at some of the research, probably maybe more even up to 10 or 12%. So this gives us a bit more information about estimated drug use. This is by New Zealand Police, just to see what sort of drugs we're mainly talking about. And as you see, methamphetamine there, much higher than both MDMA and cocaine, obviously, if you were looking at cannabis, you'd see a higher use than methamphetamine, but there's those ones. And again, this is just solely for West Auckland wastewater drug testing. Again, you see the predominance of methamphetamine, but also not an insignificant amount of MA use. And this varies really quite a bit across the country. You'd see that methadone predominance up in Northland, probably the Waikato, but probably not so much, maybe hardly any methamphetamine use in the South Island. Of course, I can't not mention cannabis use. This is just some figures that I managed to pull out, which means that if you're looking at 15 years and over, about 11% report cannabis use in the last 12 months. 7% of those users have had people express concern that their drug use, and of cannabis users, about 1% had received help to reduce their drug use. So we might have 2,000 of those people in West Auckland. And social harms by drug use, cannabis, because it's much more common, ends up with quite a big dollar personal harm and community harm there, and then methamphetamine. So I guess the next question is, does legitimate pain protect our patients from addiction to their opioids? Do you think that that's true or false? Should be quite quick for you. You've only got 50-50. And there's, yeah, so. We rely on the computer work here, I think, to produce us results. So I'm being patient. That's interesting. I think most people did say that that was false, although a third of you said that that was true. I think that in sometimes palliative care providers do say that it does protect patients from addiction to their opioids, and having pain does. And my sense is that it doesn't at all. And I think that that is actually false. But then it's very difficult to find evidence to support that belief. So how do we work with this particular patient group? And whilst, as you can see from the numbers, for a percentage of the patients on our books, which we might have 3 or 4 people, or even nobody, or 1 or 2 with substance use disorder, but they do take up a huge amount of time and energy to support them properly and well. I was listening to a guy from the States who's written a lot in this space, and he was talking about, particularly in America, where people have gone really concerned now about opioid use with the epidemics there, and that people have gone from a kind of opiophilia to an opiophobia, and really not wanting to prescribe opioids at all. Obviously, that's particularly in chronic pain, but I think, you know, we are also reluctant to prescribe it, especially with people who might have substance abuse disorder. And he argues for this balance of using addiction medicine, kind of harm minimization approach, rather than having this swinging pendulum which moves from one to another. And actually, some people have said, why bother with the active management of this in a palliative care setting? And I think that really the arguments are that treating this addiction helps to foster the adherence to medical therapy, safety during treatment. It helps with working on aspects of recovery at that last part of life. And also, we really need the social support network that they have. And if they continue to use substance abuses, sometimes they can alienate or weaken that further. So ignoring that substance use disorder can lead to ineffective pain management. We put the patient's safety at risk if we don't deal with it. They might not manage to complete the tasks they'd like to do. They might want to rebuild some relationships and reconnect with some people. And I think if we ignore it, we prevent that restoration of their self-respect and dignity. So how do we tell or who of our population might be at risk? We often, we don't really regularly screen for opioid use disorder in our palliative care setting. And I wonder if we should. And if we did, what could it look like? So I'm sure those who are primary care will be familiar with this screening tool. It's a very easy one to use. The mnemonic is CAGE. Have you ever felt you should cut down on your drinking or drugs, annoyed by people criticizing you, felt guilty about it? And finally, have you ever had a drink first thing in the morning or to get rid of a hangover? And if you score 2 or more of these, then you might have 80% risk for the disorder. I quite like this one as well. This is another screening tool that people have used, talking about, and these questions you can see for yourself, but really asking specifically if people used illegal drugs, how often in their lifetime, how often they take medication other than the way it's prescribed. And often we find people are very willing to be honest and open about the issues and problems that they have. And finally, this third one, which I also think is useful, which talks about factors that might lead to addiction. And clearly, when we see somebody who's got an opioid use disorder, there's other things going on here for the patient and also for the family often. And they may have coexisting mental health disorder. So what do we do once we've screened? I think if we screen and find that we have got, the patient has got a challenge here, then I think that affects how we monitor things and how we deal with things as coming onward with this patient. So what about trauma? We do know that patients who've got substance use disorder have got a high risk of trauma. Not everybody who've got substance use disorder went through trauma as a child, but many people, I think it's around 25% have. So we know that exposure to traumatic experience, especially those in childhood, has been linked to substance use disorders. Women with substance use disorders often report abuse, whether that's sexual, physical, emotional, or neglect. And children having with a parent with an SUD are at risk of experiencing direct effects. So when I was preparing for this talk, I sort of spent some time looking at trauma-informed care. I think that often in healthcare, we unfortunately work in silos, and myself working in a palliative care community setting, I'm so lucky to have the benefit of working with a interdisciplinary team, but some of us don't have that ability. And I think that trauma-informed care probably most likely to be talked about in psychiatric settings and addiction services. Really, it's a framework for how we deliver services to people who've had trauma affecting their lives and how that affects their service needs and their use of service, and the encouragement of us as service, those of us providing services, to make sure that we're providing a strengths-based service, that we're grounding it in understanding of and responsiveness to the impact of that trauma, and create opportunities for people to rebuild sense of control and empowerment. Often I found in healthcare we can definitely bring our own biases and even let that affect our judgment of how we treat and manage people who have substance use disorder. So this trauma-informed lens, as we could call it, changes the question from what's wrong with you to what happened to you. It seeks to understand the impact of the trauma and to avoid those triggers so that when we work with a patient, we're not re-traumatizing them. And build and encourage that resilience that they've had. Many of them do have quite a lot of resilience to bounce back from stresses, and they have things that you can work on to enhance their coping skills. Other management strategies, clearly, if you're managing the medication for this patient, then you are going to have a lot to think about. It's useful to know more about their own drug of choice, what they used or are using and how often, what they want to avoid, if anything. That also gives you useful information, and who's prescribing for them. That's really important to know, because at some stage you might want to say, we'll have one prescriber. Often there's if it's they're in the CADS program, that might be a GP or a CADS team. And now as a palliative care physician, you're adding in another prescriber. How's the medicine going to be dispensed? When they're going to pick up the medicine and how often? It's important to be aware that they are likely to have a high degree of tolerance and often need high doses to manage their pain. What do you feel comfortable prescribing? Do you want to manage things with a long-acting medication? It's hard to get away with that and not provide any short-acting, but that's one of the challenges. And how do you monitor their medication use? Are there drug interactions you need to think about if they're still using recreational drugs? How do you know, are you going to deal with that and the interactions with that and any opioids you prescribe? And I think maximizing the use of any adjuvants and complementary therapies is important, and we need to watch for withdrawal. So some of the literature also suggests that even at this stage in life, it's worth that some people might still want to engage in some sort of program that will help bring them strength. We want to support the building of bridges with people in their past. Often people have disconnected with some of their relationships. In fact, we've had quite a few patients who say moved into West Auckland because they're coming back to live with family members who they might not have connected with for many, many years. And that's actually really impressive to see, especially when you see the support and love provided by some of those family members. So you might also need to think about the families who are also maybe supporting the addiction or at risk of addiction themselves, and make sure that we provide that safe environment. There's also an issue around the risk and prevention of overdose, and I notice particularly in the States, they do sort of prescribe naloxone to give the patients at home, which is not something up to now that we've done. And the last thing I want to say in this part of the talk is to talk about how anticipatory care planning can also be a really useful. I know we talk about it often with all our patients, but with these particular patients, I think that helps them to regain a trust in healthcare systems and that they can believe that their wishes will be respected. We can address any fears that they might have, because I think that they've actually got quite a sense that they know that our painkillers don't work as well for them, and that might mean that they have a painful death. And also, if we make sure that during that, when we do that anticipatory care planning, we make sure we include any non-traditional family that might be part of their connection network. So that's the first part of the talk. The next part, we're going to go through some cases that we've had in West Auckland, and at the end of each of the cases, I'm going to bring in one of our team who's going to have also reflect on how looking after that patient was for them. Just going to have a quick sip of tea. So our first case was a 62-year-old European man. He'd recently been admitted to Auckland City Hospital after a seizure at home. He had a history of IV drug abuse, but it was some time ago, and he was on the methadone program. He'd had a few months' history of weight loss and fatigue. Comorbidities, he had severe COPD. When he was admitted, he had a very low GCSS, and the assumption was he probably had taken an overdose and he was treated with naloxone, but there was no evidence of any overdose or toxicity, and in fact, naloxone didn't make a huge amount of difference for him. His urine screening was negative. I guess that's my first reflection, because I've had that quite a bit. The first assumption, if anybody who is on the methadone program or had IV drug use in the past, is that they're probably overdosed. And whilst I know that we need to keep it in the differential diagnosis, there seems to be an overemphasis on it. So CT that he had while in hospital at this time confirmed extensive metastatic disease. Mets in the liver, spleen, peritoneum, omentum, and Brohn's. So the MRI spine showed widespread bone mets and some fractures at L2, L5, and L3. So you can already see this picture setting him up for really severe pain syndrome. So later histology after he'd been discharged confirmed that he had anaplastic large cell lymphoma. So while he was in hospital, his pain was already a challenge to manage. His methadone was initially reduced because of the provisional diagnosis of an overdose, and then gradually back up titrated, although when he was discharged, it still hadn't been up titrated back to his usual methadone dose. And that at Auckland, they used a methadone breakthrough dose at 2.5 milligrams every 3 hours, which is pretty standard for us. He was then discharged via Waitakere because to help with discharge planning locally, where his methadone regime was switched to BD, which is also something that we do at times to help with better pain control for these patients. But instead of adding the methadone PRN dose, he was given morphine, 10 milligrams every 2 hours as a PRN dose, and he was discharged with 300 milligrams of morphine. So a couple of days later, we were called out to see him. He had severe pain. He had no analgesia in the house. He'd already used his 300 milligrams of morphine and really hadn't done anything for the pain at all. So the context for him was that they lived in a housing New Zealand home. It was small and very steep staircase to get upstairs, which I think he never made it upstairs after his diagnosis. They managed to, when I first saw him, they had a mattress, double bed mattress down on the living room, and it was actually difficult. The space was so small, it was hard to get around the bed. He was on the sickness benefit. His partner, who had arthritis, was on the invalid's benefit. She was also on the methadone program, and they were both having counselling before his diagnosis through CADS. He described himself as a spiritualist who believed in a higher power. So what did we do? Morphine was clearly doing nothing at all for his pain. So we decided, and this is one method that we do, is we added in methadone for pain. So initially we kept him on his methadone program doses and increased the amount that he could have so that he had a dose for pain. And I was prescribing the dose for pain, and his GP was prescribing on the methadone program. Sometimes it's confusing for people that either could work or which is which and what's what. And so sometimes we use that in a tablet form rather than the liquid. It's usually given on the methadone program. After a few days, it became obvious that it was confusing for them to have those two scripts, and they didn't feel that was helping. And we actually took him off the methadone program, incorporated his pain dose into the methadone, and we started. And I also worked with CADS to take him off that, and the GP agreed to be the sole prescriber with us giving input into the dose that he would have. At home, when we're prescribing PRN methadone, we don't usually give unlimited amounts. We usually set it, and mostly I try to set it at a maximum of 3 a day. So 5 milligrams he could have every 3 hours, but a maximum of 3 a day. If it gets beyond that, then that's when we start thinking about increasing the background dose. So these patients who are on opioid agonist therapy, so on the methadone program in New Zealand, are usually on methadone. And that does prevent craving and withdrawal, but doesn't really impact on acute pain, when we usually have to split the dose or add breakthrough doses and have a dose increase to manage it. So sometimes we'll use methadone for breakthrough, and sometimes we'll use another opioid. And it's really all about how you manage that, how you set maximum doses, and how you try to, I prefer to use, to rely on the background dose as much as possible. So now what I'm going to do is ask Louise to join me. Louise is a nurse specialist in palliative care who worked with me most of the time on this case. Louise, I just wondered if you could give us some of your reflections about this gentleman and his environment and how he managed things.
Yeah, sure. The initial information that we got, it sort of sets you up to anticipate different things. You know, you're always looking at the physical environment that someone's in. He was in a housing complex with quite a lot of different characters around and potential impacts there. His main carer and support person was someone who's also on the methadone program as well. We're always trying to figure out what people's capacity is and capabilities are to care for someone, and just reading through that information, you know, there's complexity to his cancer, his disease, his management, which is already overwhelming. His carer, his friend, managed to take that very well in her stride. There were many overwhelming points and many things they faced together. Being on the methadone program, firstly, having daily dispensing, and then that being changed to allow for pain dosing. I do remember several times this constant fear from them of being judged for the amount of medicine they needed to use, not really accounting for his tolerance of medicines and the fact he was likely to need more. There was a lot of going back and forth from them to us to pharmacy to prescriber, just to ensure there was a clear understanding of what he was using, what it was for, and that there wasn't the need for fear of judgment. But I suppose both of them had been on this program for almost 30 years. So over that time, I'm sure they faced a lot of assumptions about perhaps who they were and what they did. I think they did an incredible job. It was, as Celia described, walking into this home with this gentleman on an air mattress on the floor, with a lot of their collections over 30 years surrounded. There was very little room to move, but that was their space. That was where they were comfortable. It was, yeah, it was quite humbling to see the support they had for each other and the care of each other, as friends. And it was a lot to learn. It was probably one of the first sort of cases for myself of someone being on the methadone program and then coming into a situation with such advanced disease, on diagnosis, and sort of how complex that was in the services involved. Once we got things more established, it actually made things a lot simpler by the end, but the process to get there was very long, very hard. So everyone involved did really well.
Thanks, Louise. Yeah, I think you're right. That reflection about their relationship. I mean, he was always thinking about her, even thinking of his own death and the impact on her. And she was like trudging up and down to get his drugs
Oh,
and other things, which was very sweet to witness. And I think it did take them a while to trust us,
yeah.
maybe particularly me as a doctor in the system.
Well, we're going in with a different lens than they've ever seen before, and talking about the different options we can try, and it's building that relationship with them to have trust and faith in what we're offering. And it did take a lot of time. I think there was a lot of times where she was very overwhelmed and would shut us out and just say, leave us for a while and we'll let you know when we're ready. And that's always hard, because when we're aware that someone's in pain and different things are going on, you want to be there to support them, but it has to be in their own time.
Yeah, and I think he was too unwell on diagnosis, as you say, for any treatment. I think it definitely did reduce the complication taking him off the methadone program. I think especially for the pharmacy, they found that they've been very cautious and careful about methadone, and suddenly we're adding more and more. And so it was hard for them, I think, to get their head around. So I think taking him off the program was actually helpful, because we're able to move forward in terms of managing pain. Thanks so much, Louise. We'll see Louise again later. Okay, so our second case, he was a 41-year-old Maori man. When he was admitted, he came with a tracker on, because he'd been released from prison on compassionate grounds. He came to us via a short inpatient stay at Total Hospice in Counties Manukau. And he'd had a recent diagnosis of an aggressive metastatic neuroendocrine tumor. He had extensive bone disease, so he had that in common with the last patient, with metastases in the ilium, sacrum, mandible, and lumbar spine. So that was really quite challenging. Going to be already, when I see that, I know his pain's going to be challenging. And this mass in the right vertex, which was suspicious for a dual met. Comorbidities, he did have a past history of epilepsy. So what about the psychosocial context for him? So he had 3 children, two daughters and a son, and they all lived in Auckland. And he'd been discharged from Taurua Hospice to his oldest daughter's home, where she lived with her son and husband. And I guess that's one of the first things that struck me, that connection he had with his daughters, particularly, who we met quite a few times, and the way that they'd welcomed him from prison out into their home with their own family. He was a current user of cannabis. He'd reported a very unhappy childhood and a high level of cannabis use when he was young. The two things that were most important to him were his faith and his family. I was just pulling in this slide here just to sort of reflect on those protective factors. I mean, I think he had managed to make strong social connections, especially with family. And that gave him some feeling of belonging, but probably didn't have many other protective factors at all. Unfortunately, his cancer was very aggressive and unrelenting. He didn't respond to chemotherapy. He did get some benefit from radiation treatment for his pain. He also had a couple of hospital admissions for his reduced GCS, which the other thing that happens is often that's because of is felt to be due to his opioid prescribing. But it was interesting in his case because although he hadn't had seizures for some time, those admissions definitely resolved after initiating anti-seizure medication. And one of the experiences that I remember, well, with him, it was at a time when I also was going into Waitakere Hospital, and I was with him, and the usual round of doctors came in, and we were discussing whether he could have oxygen at home. They knew he was a smoker, and I was only wanting to get an oxygen concentrator for him. And the medical view there was, no, we can't give you oxygen at home because it's too risky because you're a smoker. And reflecting on that, I think his relationship with his family and his care for his daughter in particular was such that there was no way that he was going to put them at risk by smoking inside. So I felt quite dismayed by the medical attitude towards that. And when he got home, he did use an oxygen concentrator that we provided and never smoked inside. He needed constant up titration and adjustment for his pain. It was extremely challenging to manage. He was on maximum medication with all these drugs, gabapentinoids, antidepressants, benzodiazepine, and we used dexamethasone with some good effect. The maximum methadone dose that he required was 60 milligrams subcutaneously, and he also received methadone for breakthrough pain relief. He did seem to get some benefit from lidocaine, which we provided in our hospice outpatient clinic. And that was when Louise met him as well. He also suffered from a refractory delirium, especially it was about the last 10 days prior to his death, which I think on reflection may well have been due to that dual met. He required quite a lot of antipsychotic medication. And I mean, sometimes it's really quite frightening how much medication you have to give or how difficult it is to control both pain and agitation in some of these patients. I remember being at his home with paramedics in the middle of the night where he was really delirious and had a lot of pain. I think he required multiple doses of midazolam, droperidol, multiple doses of methadone just to settle him down. So often people can soak up these drugs and really need high doses to help them. And ultimately, he did need a drug that we don't use often, but occasionally, dexmedetomidine, to manage his delirium. And happily, he was able to die at home with his daughters present. Louise, can I bring you back in to because I think you were involved also with this case.
Yeah, sure. I was just thinking a similar time for myself and one of the other people joining on the panel, sitting at this gentleman's home. A very distressing time, I think, for us, for him and his family, just giving medication after medication for that delirium. And I think that him being a young person in himself, his young daughter, and just seeing how well she um, was able to be there and be present and support him for that. Because I think as a health practitioner, waiting for the moment where you finally can get some control and get some stability for him, it's quite an anxious time. I can't really imagine what it was like for her, but she did incredibly well because it wasn't a once off. Unfortunately, there was occurrences that did come up again, just the same as you. But I think I mentioned the other day the biggest thing that I remember about him, the information we'd received. There's all these negative connotations about him, where he's come from, his previous history, his drug use, and what that could mean for a person like him. And then sitting with him during this infusion, which was most of a day, um, and I remember coming away thinking, oh my God, he's just the loveliest person. He was just so sweet and so kind and so gentle. And I think that's where we get that information and automatically create this character, this assumption of what he should be like, knowing that information. And it just really took me back, just to see what a kind person that he was. And every time going forward, even those states of pain and delirium, meeting him, he was always so gentle. And you could, it wasn't him causing these things to happen. It's just a part of that process. But he was always just the loveliest person. So I can just imagine with his history how things as well might have been for him on different occasions, knowing his history and perhaps how people have treated him or maybe assumed um, things of him that weren't actually the case.
I definitely think he almost expected that attitude.
Yeah,
um,
definitely.
yeah, and it was really interesting and lovely to see that very kind, caring side of him.
Hmm.
And I remember his daughter saying to me, "Oh, he's such a lovely man when he's not on P."
Oh,
And I think that was the reality. He just had this lovely personality and caring, and clearly managed to keep these connections where his daughter was prepared to do that for him.
mhm.
So that really helps us see into that real person, eh?
Yeah,
Um,
definitely.
and we did. I remember before he died, we managed to get the tracker off when he was in hospital. We worked with corrections to come and take that off. Um, and I remember I think it was his daughter saying that the person who came to take it off seemed terrified. But why? He was really ill and unwell by that time, very weak. But yeah, I think we all have this kind of fear and fear of the unknown, I guess, as well. And I guess we're in a very privileged position to get to see this other side of people.
Mm.
Thanks, Louise. Okay, so our last case before we go to the panel discussion was a 50-year-old New Zealand European man. He'd presented, this was out of our area at this time, in March down in Waikato with abdominal pain dysphagia. And finally, he'd had an endoscopy with reading a fungating, obstructing circumferential GOJ mass, which was later confirmed of invasive adenocarcinoma of his gastroesophageal junction. So he had had a stent placed, and he'd had his PET scan had showed this mass, which was quite huge, 8.3 centimeters already on diagnosis. And almost immediately it was decided that he couldn't have his chemotherapy and he was moved to best supportive care. He had quite a lot. His past medical history included quite a few things, including COPD and asthma, which definitely affected him when we saw him. Low mood. He had chronic back pain after a back injury, and he was a regular cannabis and methamphetamine user. So what about his context? He had a son who was in his 30s that he seemed to have a really good relationship with. He'd mainly brought him up as his mother was an alcoholic, and his son had gone on to have a wife and 2 children of his own. He'd also had a second relationship with a woman who had, and the 2 children that he had with her had were taken away, again for addiction reasons. He'd come to West Auckland to live with his mother. Since his diagnosis, he lived short times with both his sisters, but I think that came unraveled, and he ended up coming back to West Auckland, to the home where he was brought up, to live with his mum, who herself was actually quite elderly and frail. He had low health literacy, and he was struggled to read and write. His father had left him when he was about 5 years old, and he often talked about a lot of losses in his life, especially in regard to relationships. He didn't have any spiritual beliefs, and the thing that he really hated most was the fact that he had now become dependent on other people. So pain, again, was quite a big issue for him. You can see even when we first met him, he was already on quite a lot. MDE here is morphine dose equivalent. So fentanyl patch, he'd doubled the patch himself. He just added a second patch a few days before we met him. And he'd also somehow managed to get 3 different antiemetics for his nausea. He was using cannabis. So yeah, that was the picture when we first walked him. Actually, I remember coming to the house for him, and there was a thing on the door saying something like, please don't knock, or please don't knock on the door. I think which was already quite an interesting first meeting. So after speaking to him and analyzing the situation, I felt that methadone was probably the only drug that was likely to manage his pain. He wasn't on a methadone program, but he really wasn't interested in taking methadone. So we wanted to make a start and try and build trust with him. He was happy. I think the interactions of all these drugs were not helping him. We ended up stopping all the antiemetics and starting him on famotidine. He was getting a lot of gastritis, and he agreed to stop the tramadol, but he wasn't keen on changing anything else. But later he did call us about a week later, saying he wanted to switch to methadone. I think he toed and froed for about 48 hours, but finally he agreed that switch was what he wanted. The pain was really severe, really from his central and lower chest area at the site of the tumor and the stent. So the way we did that switch, we did do it in the community. We did it using a syringe driver, so we didn't have to try to make, because it's quite complicated the way we switch it with 3 steps titration method. So we did do that with syringe driver, and every few days the mix in the syringe driver changed until we could get him onto the methadone, and he had a significant reduction in his pain, good response after the second titration of methadone. He didn't want to make the final step of taking off his 50 microgram patch, so we left that on. And he'd also agreed to meet with one of our counsellors, who you'll see in the panel, Amy, but unfortunately, just before I think he was meeting her the next day, he had a massive GI hemorrhage at home and died there. So yeah, that was another interesting case. Stephanie's going to join us now, our nurse practitioner, and she was also working with me with him, and will give a bit of a reflection.
Thanks, Celia. I think very much like with what Louise said, so this gentleman came to us from Waikato, and we didn't have a lot of information, and we had lots of little sort of pieces of information around. He was a 2-person visit, and he had some estranged relationships with family, and he had gone back to West Auckland to be with he was in his childhood home actually with his mother, who was also, like you said, elderly and had some of her own health issues. And when I first walked up, I think the sign that Celia said as well, please don't knock on the door. And then a neighbor came running out and was like, oh, we're just checking that things are okay there, because there had been a police car there yesterday. So I sort of walked in not knowing what to expect. And when I walked in the door, I just saw this gentleman who was lying in his bed, and he was in so much pain and just he was so cachectic and looked so unwell. And kind of a mess. There was lots of stuff in the room, and he was lying in the bed, and you're sort of, as Louise described before, you're climbing over things. And I think he just was really grateful for anything to sort of help. He was really in significant pain, just couldn't even get up at that point. And I think after the first sort of 24 hours with the methadone, as Celia was saying, we finally got things a little bit under control with his pain, and it's never perfect. It was quite messy. He was quite adamant he didn't want to stop the fentanyl patch, and we were quite happy with that. But the resilience, sort of along with the family, we knew that there was some estranged relationships, and he had this beautiful relationship that with his son, who was from Rotorua, who eventually came up to see him. But he had this sort of developed this strength through, they had been estranged at some, they had different periods, the son had told me, where they had less communication with each other. But over those last few days, he had been having a lot of text. They had been texting a lot and communicating. And I think both the patient and the son had said to me how this was really meaningful towards the end. And it was just, for me, looking back, it was just a less than perfect scenario, but you sort of work with what you have.
Yeah, thanks, Stephanie. Again, those relationships, I think the other person who ended up coming back to help out was a former childhood sweetheart of his who
was there actually when he, after he died. It was quite beautiful. She was very happy to help support the family.
Yeah, so we do rely on those connections, and it makes such a big difference to us if we've got somebody who's, and all three of these cases had built some connection there. Thanks, Stephanie. I think I'm going to move us on because I know that time's moving on, and we're now going to ask the other panel members to join us. So you've already met Stephanie and Louise, but now we're going to ask Amy, who's a counselor in our team, and also Patricia, social worker, to join us. I have to say that one of the things I love about my job is working with an amazing interdisciplinary team. It just brings such richness, and it's just lovely learning with them. So since you've already met Louise and Stephanie, I'm going to go straight to ask Amy first about her reflections about these cases and how she would approach things. Amy, over to you.
Kia ora, thanks, Celia. I think, I just want to tautoko what has already been said a lot with what you were saying, Celia and Louise, around, the importance of noticing your own biases or assumptions or judgments around people that might have substance use in their lives. So just checking for that when you're working with them. And I think for myself, like not going in with an agenda around what I think should happen. I think drawing on what you're saying there, Celia, around the trauma-informed care, that it's really important that they have a sense of control and autonomy around what they want. So working in that really collaborative way with where they're at with their substance use. What else? Yeah, it's just really lovely to hear you speak about them in such a strength-based way, like really beautiful, really important around seeing them outside of their problems or their use, and seeing their relationships and their connections and really valuing that, seeing them as sweet, and so that they're that whole person. And just the emphasis on, I think that's really humanizing, right? So that they get to have an experience, even at this point in their lives, experience themselves in a different way because of the way that we're relating to them, if they've often expected ill treatment or a particular type of treatment by medical practitioners or a system. Yeah.
Thank you.
Yeah.
Yeah, it was a shame that I wish that last patient had met you. I think it was such a great step that he took with saying that he would coming to you. So it was a shame that he just didn't have that bit more time.
Yeah.
So Patricia, I might bring you in now if that's all right, because obviously these patients provide a lot of complexity in the social space, especially around just housing and connections and support, especially as they get more unwell at the end of their lives. I'm sure that you've had a lot of experience there. How are there some reflections you'd like to bring to the panel?
Absolutely. Thanks, Celia. And as everybody said, being part of an interdisciplinary team, it's so valuable that we each have a space in which we work, and we work best with these people, and so that we come together and decide how that's going to happen. And I think particularly for the social work team, we tend to get into the carer space, the family whānau of the patient, who are often, as Celia mentioned, they tend to be a bit new on the scene because somebody's come home to die within the family space that they haven't been part of. And so there's this adjustment to being with somebody that they haven't had a lot to do with, and maybe previously the relationships weren't so wonderful. And so we spend time supporting, reassuring them in the importance of their role, sitting and listening to what's going on for them, asking them what will help them to be a carer. One of the things that comes up often is, how can I get a bit more sleep? We know that caring for somebody really unwell becomes a 24/7 job. And if you're doing it on your own or with very little support, it's pretty tricky. So and then checking in with people, because they don't tend to come back and say, hello, I need this. It's like going back. How are you getting on? What else do you think you need? Doing more listening. And it's very gratifying to hear the appreciation that carers give to us for just being there for them at this particular time.
Thanks, Patricia. I was just reflecting, we were lucky that those patients had carers and people around them, so they were able to stay at home. Obviously, sometimes that's not the case for these patients. I just wondered if you could talk to us about, if they did need to go for longer term support. Is that a challenge, and how do you get around that?
Yeah, absolutely a challenge, and very often it's the challenge of moving in somewhere where somebody else might be taking control of the situation, taking control of their medications, and that's pretty tricky to even imagine going into somewhere like that. So very often we may end up somebody moving into perhaps an inpatient unit just at the very end where things are perhaps needing that 24/7 care that the family are really, really struggling with. But it is a very challenging area, and to be able to maintain people in their own home, I think, is really the ultimate thing, and we've managed to do that really well, and I'm pretty proud of our team.
Great, thanks, Patricia. We've just had another specific question come through. That is, what are our thoughts about the approach to treating pain in someone who've had a previous drug dependence history but no longer does, and they may have been on the methadone program but no longer are? And I think that's where kind of end up having your own risk assessment. If we do start them, for example, on a short-acting opioid like methadone or oxycodone, then we would be keeping a very close eye on that as it first starts. And I think you very quickly pick up if that person's medication use is accelerating very quickly, that actually that drug's not going to be great for them. And I think it's about also maybe having an agreed plan, being quite open about their previous drug use, agreeing how you're going to move forward, and how you're going to manage that drug use, that problem. Because I personally find that if someone has had previous drug dependence history, they are still likely, one, they're still at risk, because we know that some people, they've been able to get off drugs or alcohol for years, but directly they have one drink or one smoke, they're back in that addictive with that addictive problem. So I think we have to be particularly careful with those patients. So it's working with them, making sure that we're open and overt about what we're doing and why, making sure we have a clear plan and monitoring them. But also I would have a low threshold for using methadone in those patients. Yes, thank you very much. We haven't got much time left, and we haven't got a couple of more slides, but Stephanie and Louise, do you want to add anything? Is there anything you're burning to add here for the panel? No worries if not, but if you, okay. All right then. Thanks very much, guys. I'll just share my screen again. Hopefully that will work with the last few slides. Okay, so I guess a plea from us that we would really appreciate early referral of these patients. They do take significant amount of time, and it gives us most chance of connecting with them and enabling them to have the best sort of recovery at this phase of their life. So it's just left for me to say thanks very much for joining our webinar this morning. Please complete the evaluation form, and we have Dr. James Heaton will be running the next one in May, and he's going to be talking about palliative care in renal failure. So I'm just going to close with a karakia. Sorry, I need to put my glasses on for this one. Kia whaka iri a te tapu, kia wā a te ai te ara, kia tūruki whakataha ai, homia, huia, taikia. Restrictions are moved aside. The pathway ahead is clear to return to everyday activities, unified, together, strong. Thank you for all for joining. Go well.